Good day, esteemed colleagues. We'll start the second day of our conference. Today we'll talk more about the bile duct disorders, but of course we were unable to make single topic demonstrations. So in our operating discussions, our social discussions, we will talk in more general about the biliary zone discussion. I would like to remind that our conference has been translated on several resources. One is several web resources of translation. First is so to get the access, you have to register at the website, and your errors will be sent to all our partners. So in our base, we watch through all the websites, the stomach surgery school, hepatobiliary surgery school. So we have those links. We'll send you the links there. You can get enter your password, and you'll get the access to this website. Take into account the launch of this program. You can, if you like, you can get an access, you can get login and the password, which we provide even to our partners. Even at the break time, you can get login and you can get an access data sent to your friends and partners if they're interested in this topic. So you can enter the login and password and watch it in HD mode. And now the web resource provides a translation from our partners, and it's a free access actually. So by coming to the website of this resource, you'll hear about it later on. Anyone can actually see the translation for our entire conference. So can I have the presentation, please? And briefly, I would like to open up the second day of the conference starting with the topic of the multidisciplinary approach in the multi-profile hospital. But today we're talking about some specific issues of pancreatobiliary surgery, and I would like to draw your attention to what was so much talked about by our foreign colleagues. We even have not been expected that we're in such a similar trend. And it became quite obvious that multidisciplinary approach is at the moment the main way of development of the surgery. Not only the surgery per se, but of the entire clinical medicine. Why? Well, I would like to draw your attention briefly that from, so to say, general point of view, from philosophy point of view, the process of knowing the patient can have origin from different approaches. It could be systemic, interdisciplinary, but today we'll talk in a mono and multidisciplinary way of assessment. Of course, what we learned in the universities and the residences, of course, we mostly learned monodisciplinary approach, and we're not criticizing it. It's very important. It's a very important way to go. Of course, it implies improvement of your professional skills within one specific trade. And since we're talking about endoscopy, I would like to give you the example how rapidly develops endoscopy. Since today we see the image not with our own eyes, but we look at the HD monitors, where we can get much more of information about the pathologies we see. We use various dyes to improve contrasting. We use special examination modes, making possible seeing some specific structures, in particular NBA mode, which visualizes better vascular structures. It shows us angiogenesis better. Zoom endoscopy, at the moment being combined with confocal laser and the microscopy, it actually makes possible live microscopy in patients. And all those achievements, they look quite fantastic. But naturally, being within the monodisciplinary mode, we have some limits for development. like it is shown in this slide, were within limited plane of monodisciplinary approach, and to develop further, we need interdisciplinary and multidisciplinary approach. And one of those examples is endosonography. That's the topic of our symposium. It unites ultrasound capacities of one field of knowledge. One specialist who was involved in all his life into the ultrasonography, and of the endoscopist who looked at the pathological objects via endoscope. In such mix, such an interdisciplinary approach resulted in a qualitative revolutionary breakthrough. And today, in general, we're saying that such merge is very important. And of course, it expands the realm of interest of separate specialties, and different traits, they get, so to say, into each other, and they penetrate into each other. And so disease today, they do not look as a disease of one specialist. We're talking not about treatment of one disease. Like simple example, surgery or bleeding. It was always a surgical problem, but today we see the bleeding patient, we consider such patients as only surgical. But look at the European consensus statements on bleeding treatment. And you can see that in the sixth statement, it is said that the surgeon is called first time if the treatment of the bleeding is a failure. So in other words, in Europe, they consider surgeons outside of the treatment of bleeding patients. In our Russian statements or settings, we cannot do that. But think about that. If that look like medicine develops, we see surgery being changed. It acquires and it changes the way it works with patients and interacts with other fields. Here you see the comparison of mono and multidisciplinary approach. So those white rounds is a sphere or realms of one specialist, and the red dots is the disease. If the disease is within the one trade field, it could be treated. Acute appendicitis is a field of interest of the surgeon, and he could treat this patient successfully. No disciplinary approach is required, but if the disease is somewhere on the borderline of different traits, that's going to be a problem, and this problem cannot be resolved via monodisciplinary approach, or it will be low-quality solution. So expansion of sphere of interest and mutual penetration of different fields results in the conglomerate, the team conglomerate of knowledge and skills that's united interdisciplinary team. And those problems which were on the borderline of different specialties could be resolved through this teamwork. And we today see different, so to say, we can see different ways this interdisciplinary approach is emerged. For us, it's not enough just to make a diagnosis. We try to have results of CT, MRI, or endoscopy. We like to have additional prognostic criteria. Just one short example, which you could see, which you remember yesterday, is the stomach cancer. What more you need? It seems to be enough. Endoscopy, stomach cancer, histology confirmation. So could you do the surgery? But today we're coming to endoscopists and we ask them, please make us stage the disease. Please think about prognostic criteria. What is the TNM staging? Are there any involvement of regional lymph nodes? Which lymph nodes are involved? In which direction we should increase lymphodissection? Which should be more intense? And all those issues should be answered by the clinician. So diagnostic specialist works, diagnostic diagnostic specialist actually looks at the surgical situation, and surgeon looks at the diagnostic situation. He compares the surgical view, and diagnostic specialists understand what surgeon is asking for. And surgeon being a diagnostic specialist in MRI or CT looks not only at the diagnosis, but looks if if it is operable. It looks at the TNM, and also he thinks on the issues which will help the surgeon to plan the surgical technique on the basis of volumetric reconstructions, and thus it provides a more complete or better quality interaction. Therapists and surgeons, I don't want to comment on that. You can see the importance of this union, and we're talking about that all the time. Different surgical fields, like vascular surgeons, they come to the cancer surgeries, and of course medical and technical fields. Today we have lots of equipment, and if it works right, if it is safe, like electric surgery, there is a range of issues to be taken into account. The surgeons should interact with companies, with new developments, with technical support. That's a research and technical module or cluster, and it requires making those interactions, or brings those interactions to new, higher quality levels. I also would like to say that the prognostic vector of diagnostic programs actually is seen in all fields of medicine. No matter which field of medicine we think of, all the classifications, they are prognostic oriented. We're not interested to know if it is a large or small nodule cirrhosis. We're not interested in that. When we talk about hepatology, we think about the survival prognosis, like Child-Pugh criteria. With biopsy, we're not interested in the descriptive part. Our morphologists can describe quite nicely what they see in biopsies. But we're interested in very clear prognostic or digital criteria, which makes possible making some specific solutions or decisions. Acute pancreatitis, Ranson and Balthazar criteria, of course, they looks to be a little bit of obsolete these days, but still, new ones appear. Critical conditions, Crohn's disease, esophageal varices. Previously, it was just descriptive classification. Today, we use Japanese classification on the of the Association on Liver Disorders, which clearly stratifies bleeding risk factors. And in a digital format, you can see the real figure for the bleeding risk. Also, bleeding forest classifications. It's also prognostic. Also prognostic quality. The same happens in surgery. That's an example of interaction of surgeons and pathomorphologists, dissection of lymph nodes, or removal of lymph nodes. Today, prognosis is mostly determined the way the lymph nodes are involved. If you resect them poorly, there will be error. If pathomorphologists didn't see the pathology, it will be an error. So it will be understaging. So appropriate mapping of lymph nodes, not just resection, taking into account the total number of removed lymph nodes, but mapping of them, but labeling them. That's a teamwork. The surgeon and pathomorphologist with a fresh specimen, they work together. That's a Japanese photo, because we took this model from Japanese surgical schools due to through the assistance of Olympus company. So that's the way they cut out and put the lymph nodes, put them into specific vials, and sent to pathomorphologists. And it's all done in one registry. We're working on such a registry, and all our what we see these days is that we need to create the Russian registry on lymph node involvement, and it will, of course, be the basis for lymph dissection, so to say, volumes. And of course, there are different ways on managing this multidisciplinary team. It could be autocracy or democracy. In every particular situation, we try to choose the optimal method. Autocracy is required in a situation where we need to make clear-cut and highly responsible decisions. For instance, it's an emergency team. This team has a surgeon on duty in the process. His opinion is final, and it's not the matter for discussion. He's fully responsible. And there is a democratic disciplinary approach. When we sit with the whole interdisciplinary team, and every specialist has one voice. Endoscopist, oncologist, surgeon, morphologist, they contribute something, and the final decision for the good of patient is taken in the democracy way, and patient opinion is taken into account because the patient can veto any decision. And couple word about the ideology on management. It's different in Europe and in Japan, and here we should be very, very careful about those trends, and we should take into account both achievements of European and Japanese management schools. While Europeans mostly look at the management as taking ideas from the manager group and conveying them to the, so to say, the staff. In Japan, the art of management is when the chief, when the head mobilizes, unites intellectual potential of the employees and stands up at the position, so to say, lower than the subordinates. He considers them as a bit superior to him. So it's quite interesting to see how those links are, so to say, made. Since the last slide, we're short of time, sorry. It shows the real teamwork.